field by developing the first mouse models of inherited arrhythmias, specifically of long QT syndrome, which really established a paradigm by which to study these heritable electrical disorders. And in fact, ever since, he's been really at the forefront of investigating novel mechanisms by which ion channels are regulated in the heart, in both health and in disease, and how their dysregulation can lead to a number of heritable arrhythmias, which we'll hear about today. For me personally, your work, Barry, has always been a source of inspiration for both its rigor as well as its innovation. And as you know, I've been really following your work intently ever since I was a graduate student with David. I think you remember those days well. And so I am delighted that you were able to join with us today, and I look forward to your talk. Welcome.
So thank you very much, Fadi. You guys are all too kind, and it's my honor to be at Yale. And I hope that, in the future we can actually start doing some of these in person again. So I have nothing to disclose, and I'm going to start out with a case, and I'm going to use this case partly because this is what first got me interested in the field. At least the clinical side of it. So this is the EKG of a 15-year-old girl who grew up and was living in suburban Boston back in the 1990s. She had no medical history, no family history, and was sitting at the pool on a warm summer afternoon when her kid brother, snuck up behind her and poured a pail of cold water on her head. Her response to that was to faint. She was witnessed by her parents. She was unconscious for about 15 seconds, woke up feeling fine. And, her parents, who didn't like that, took her to Boston Children's Hospital on Saturday evening. At that time, when you're seen in the emergency room, if you weren't particularly acute, you weren't necessarily seen by an attending. So she was seen by the resident who was running the ER at Boston Children's. This was her EKG. And for those of you who are EKG aficionados, you note that her QT interval is somewhat longer than it should be. That was not appreciated by the resident at the time, who did a history physical, did this EKG, and said that he thought she was okay and sent her home. But he was impressed enough by the story that he actually put a Holter monitor on her and gave her and her dad the Holter and said, if anything happens, here's a diary, write down, what's in the diary. The next is the control tracing from the Holter. And you can see that her QT interval here is over 600 milliseconds long, which is markedly prolonged. So anyways, Monday morning, her dad brought the Holter back along with the diary. There was a single entry in the diary, which was nightmare, and that is the rhythm that corresponded to her nightmare. As you guys will know, that's a rhythm called torsade de pointe, or polymorphic ventricular tachycardia with a rotating axis, which is pathognomonic for inherited long QT syndrome. Couple things we'll never know. Did the nightmare cause the arrhythmia, or did the arrhythmia cause the nightmare? Second thing we'll never know, how many nightmares did the resident have who sent her home, that night? But anyways, she has inherited long QT syndrome. At the time, there was no molecular diagnosis for it. Subsequently, we know that she has a mutation in the potassium channel PERG, the second most common inherited form of long QT syndrome. So cardiac arrhythmias are a major cause of morbidity and mortality, probably around 300,000 sudden deaths each year in the United States, many more worldwide. Pharmacologic treatment to prevent sudden death is really not very well developed. Aside from beta blockers, not very much actually works, and beta blockers don't work all that well. Most arrhythmias are associated with structural heart disease, MIs, heart failure, ischemia, but some are associated with these rare inherited arrhythmia syndromes like long QT and Brugada syndromes. And we've learned a huge amount about how the heart works by studying these inherited arrhythmia syndromes. And that's sort of what we'll talk about today. This is a partial list of the inherited arrhythmia syndromes. The most common ones are the autosomal dominant long QT syndrome and Brugada syndrome. Some others like short QT are extremely rare. There are inherited forms of common arrhythmias like atrial fibrillation. where the inherited forms are actually quite rare. In addition to the really pure inherited arrhythmia syndromes, there's also, the cardiomyopathies that are inherited that come free of charge with inherited arrhythmias. And those include ARVC, hypertrophic cardiomyopathy, dilated cardiomyopathy, non-compaction, and restrictive cardiomyopathies. I won't talk about these today, given, sort of limitations in the amount of time that we have. So I'll just mention them briefly. Why do labs like mine study inherited arrhythmia syndromes? Well, even though they're rare, for the families that have them, you can actually make a real difference in preventing, people, young, healthy people especially, from dying suddenly. But as I mentioned before, we also hope that we'll learn something about how to prevent the more common arrhythmias by studying these inherited forms of the arrhythmias. A couple of minutes on, sort of electrically how the heart works. So cells in the heart and the whole body are little batteries with the inside of the cell about 90 millivolts, negative to the outside of the cell. Why is that? We have a sodium-potassium pump in the membrane, which pumps potassium in and sodium out. Intracellular sodium is 140 millimolar, blood sodium is about 5 millimolar, sodium is the other way around, 140 outside, about 20 millimolar inside. You put potassium channels in the membrane. They're proteins that are permeable only to potassium. Potassium flows down its electrical gradient or its chemical gradient, 140 outside, 5, and 140 inside, 5 outside. Eventually, that leaves behind a negative charge, and eventually that negative charge prevents additional bulk movement of potassium outside. There's something called the Nernst equation, which tells you the equilibrium, and if you plug in 140 and 5, you get minus 90 millivolts. If you're a liver cell, you live your entire life at minus 90 millivolts until your host goes out drinking, at which point you die and your voltage goes to 0, and that's the electrical life of a liver cell. If you're a brain cell, a skeletal muscle cell, a heart cell, you use changes in voltage to signal in the heart to signal the onset of contraction. So how do you change the voltage? You close the potassium channels, you open sodium and calcium channels, sodium 140 outside, 20 inside, positive charge rushes in, the voltage goes up to about plus 10 millivolts. You then close those sodium channels and you hang out at around 0 millivolts for about 300 milliseconds, and then you open a new set of potassium channels, which brings you back to minus 90 millivolts, and you reset for the next cycle. The surface EKG is the surface manifestation of current flow related to those voltage changes in the heart. The P wave is the spread of the activation wave across the atrium. The QRS is the spread of activation across the ventricle. And the T wave, non-synchronous repolarization of the ventricle. So during the ST segment, the whole heart is depolarized at about plus 10 millivolts. If you're talking about something like QT prolongation or long QT syndrome, how do you make the QT interval longer? Well, you make the action potential longer. How do you make the action potential longer? Well, you can either have broken sodium channels that don't close properly and keep the action potential up, or you can have broken potassium channels that don't open properly, and that makes the action potential longer. And turns out that's the molecular basis of long QT syndrome that we'll talk about in a minute. Now, as I mentioned, the change in voltage has a function which is the signal. So when you open the sodium channels, that leads to opening of calcium channels. Calcium rushes in, leads to the release of more calcium from the sarcoplasmic reticulum, which causes the cell to contract. You then bring your action potential back to minus 90 millivolts. You suck the calcium back into the sarcoplasmic reticulum. The cell resets and is ready for the next heartbeat. This is a subset of the genes that have been identified as causing long QT syndrome. There's different levels of evidence for each of these as to how certain it is that they are causal, but suffice it to say that these, for the most part, really are causal for long QT syndrome. There's 1 or 2 more that are added each year, and I could take this down to about 19 now. These are mostly potassium channels that don't open properly, sodium channels that don't close properly, helper genes, so beta subunits and trafficking genes for the potassium channels and the sodium channels, and a few that we don't know exactly how they work, well at this point. Now, clinically, the only important ones are really the top three. So LongQT1 and LongQT2, which are the potassium channels that cause, LongQT1, KCNQ1. This causes approximately 50% of genetically identifiable LongQT syndrome. This is the potassium channel that shortens the action potential when you exercise, when your heart rate goes up, when beta adrenergic stimulation is present. So mutations in this gene cause sudden death with exercise, one of the several causes of kids who drop dead on soccer fields. LongQT2, the hERG potassium channel, which is another potassium channel responsible for repolarization, this causes 40 to 50% of genetically identifiable LongQT syndrome. And this channel is mostly notable for the fact that it's also the cause of acquired LongQT syndrome. We'll talk about that in a little bit. Now, in addition to the potassium channels, the sodium channel mutations that cause inherited LongQT syndrome are LongQT3. These are mutations in the inactivation gate of the cardiac sodium channel NAV1.5. And here, these mutations cause about 3% of genetically identifiable LongQT syndrome. And then all the rest of these cause, individually way less than 1% of identifiable LongQT syndrome, and together only 1 or 2%. So these are all rare. These are relatively common, especially the autosomal dominant potassium channel mutations. So how does a LongQT syndrome mutation actually cause the clinical condition? Well, the mutations in the potassium channels subunits lead to less outward current. So potassium channels takes 4 subunits to make a functional channel, and the mutations decrease the amount of functional channels. They can do it by ruining the RNA or leading to or preventing expression of the protein, so you get fewer channels. They can affect trafficking of the channels to the membrane, so the channels are perfectly fine if you can get them to the membrane, but they get degraded intracellularly and never get out to the membrane, and that's particularly important for the hERG potassium channel mutations. You can make the channel that can get out to the membrane, but it just doesn't work. Maybe the kinetics is such that to open it has to go to a voltage that we'll never actually get to, and there's many examples of channels like that. Now, for the sodium channels that don't close properly, they lead to increased inward current by a persistent late current. So for the sodium channels, they open and most of them close within a couple milliseconds. But for people with inherited LongQT syndrome, LongQT3, a higher fraction of the channels don't close properly. Instead of 0.2 to 0.5%, it can be as much as 3% of the current remains late, leading to a longer action potential. In addition to sodium channels, calcium channels can do the same thing if they don't close properly. And there it's really changes in the time and voltage dependence of inactivation that lead to the inherited forms of LongQT syndrome due to calcium channel mutations. So I mentioned that it takes 4 potassium channel subunits to make a functional channel. That leads to something that we talk about called a dominant negative effect of the channels. And that goes something like this. So it takes 4 wild type subunits to make a functional channel. If you have a mutation that just decreases the number of channels, say one of the 2 copies of your genes that don't express, you have half as much RNA, half as much protein, you'll have half as many functional channels. You'll have usually a mild case of LongQT syndrome. If, on the other hand, you have a mutation that affects the kinetics of the channel, say, and that mutant subunit is still able to pair with the wild type subunits, and if a single mutant subunit is enough to make the resultant channel non-functional, then if you do the math, only 1/16 of the channels will actually work. So dominant negative mutations that don't eliminate the RNA of the protein, but actually mutate it to something that is non-functional, even if only one of the 4 subunits has it, are much more severe. And that turns out to be true, although we usually don't use it clinically yet because we, haven't quite figured out, sort of which ones are which, at least, at a large enough stage to sort of use it clinically. Okay, so you have long action potentials. How do long action potentials lead to arrhythmias? Well, when we talk about arrhythmias, we usually talk about things that initiate the arrhythmias and then things that, let them actually continue. So starting about initiation, we think about increased automaticity. So usually the pacemaker is the SA node. If you have an alternate pacemaker in the ventricle, that can take over and pace the heart fast and give you a tachyarrhythmia. That's usually not the mechanism of long QT syndrome. The mechanism is referred to triggered activity. And these are early after depolarizations or delayed after depolarization. So basically, when you have a beat, you get a second echo beat that follows it. In early after depolarizations, what happens is normally, the sequence of channel openings and channel closing is scripted. You open sodium channels, then you open calcium channels, you close sodium channels, you close calcium channels, you open new potassium channels. If the action potential is too long, the calcium channels can open, close, and then try to reopen. And if they reopen, that leads to a repeat inward current and can trigger a second action potential, which then can lead to, if they propagate, to reentrant arrhythmias. And action potentials are too long in long QT syndrome. The other mechanism are delayed after depolarizations, or DADs. So if you have a calcium overload, if the cells overload with calcium, the sarcoplasmic reticulum can spontaneously dump calcium after a heartbeat, and that can lead to spontaneous depolarization and new action potentials. And if the action potential is too long, you get more inward calcium current, and that can lead to calcium overload. So long QT syndrome is sort of a poster child for doing both of these, which can lead to the initiation of arrhythmias. Now, once you have the initiation beat, you need reentry to have it actually propagate. So you need a spinning circuit in the heart. So how do you do that? To get reentry, to get a stable spinning circuit, you need slow conduction and you need a barrier. And slow conduction happens with sodium channel mutations. So in long QT3, that's a major important mechanism. For anatomic most barriers which happen in structural heart disease are anatomic. They're scar, most commonly fibrosis. And so you can have rhythm disturbances spin around areas of scar, where there's slow conduction. Now in long QT syndrome and the other inherited arrhythmias, you don't have scar usually, but what you do have is you have the functional equivalent of that. So in long QT syndrome, the action potentials are long, but in some parts of the heart, they're a little bit long. In other parts of the heart, they're really, really long. And they can be so long that they actually cause conduction block and act as functional barriers to propagation. And so you amplify the native heterogeneities in the heart, apex to base, endocardium, epicardium, Purkinje to endocardium, and that can lead to the presence of reentrant circuits that will then allow for the maintenance of arrhythmias, and the substrate. Okay, clinically, let's talk a little bit about long QT syndrome. Comes in 3 forms: autosomal dominant, which is the more common form of the inherited ones, and that's a single mutation of one of your 2 genes is enough to cause inherited long QT syndrome. So if you have it, 50-50 chance you'll give it to your kids. Your brother or your sister have a 50-50 chance of having it, and you got it from your parents unless you're the first person who has the mutation. There's an autosomal recessive form, and for the KCNQ1 or long QT1 form, or its beta subunit, which is long QT5 or KCNE1 mutations, these are homozygous mutations that are associated with very long QT, very severe arrhythmias, often present fetally, and also congenital deafness. Why congenital deafness, you ask? Because this potassium channel, in addition to being in the heart, is actually present in the inner ear cells, and you need some of this potassium channel to make endolimbs. So if you don't have any of this channel, if you're homozygous, knockout for this channel, you won't have any endolifts and you'll be congenitally deaf. Now think about it. If you have autosomal recessive, Jervell-Lang-Nielsen syndrome, then both your parents probably are autosomal dominant Romano Ward, usually with a mild phenotype. Now, in addition to these two, and this is very rare, this is less than 1 in 100,000 people. Now, in addition to the inherited form, there's actually an acquired form of long QT syndrome, and this is common. So probably about 2% of people are susceptible to developing long QT syndrome in response to pharmacologic agents, drugs. And this is the bane of the pharmaceutical industry, because a lot of drugs, it turns out, bind to the very prolific pore of the hERG potassium channel. And the idea here is repolarization, something called repolarization reserve. So the idea is that some of us don't have as much repolarizing potassium channel as others of us. And although under normal conditions we have enough and there's no real problems, if you take one of these drugs that bind to the hERG potassium channel, then you will then get functional long QT syndrome and all the arrhythmias and potential for sudden death from it. And this, like I said, this gets in the way of the pharmaceutical industry in drug development. Now, drugs are tested for binding to hERG, and if drugs block the hERG potassium channel, they stop. Development of those drugs stop. Now, there is not a one-to-one correlation between how well drugs bind to hERG potassium channel, and to be honest with you, I'm not sure that I think the mechanism that people think of repolarization reserve is a little bit overly simplistic, and we're trying to sort of refine it and come up with some other ideas that might help, sort of identify which drugs are more likely to be severe. Okay, clinically, what are the features of long QT syndrome? Syncope, sudden fainting, sudden death, unexplained seizures. If your brain gets no oxygen, one of the things you can do is seize, and sudden infant death syndrome, or SIDS, also late-term miscarriages. So if you're a baby and you have one of these inherited arrhythmia syndromes and you drop dead, you get lumped into SIDS. People are doing molecular autopsies. Mike Ackerman's group was the first one who sort of really popularized this. And turns out probably as much as a third of sudden infant death syndrome are actually, these inherited arrhythmia syndromes manifesting themselves in babies. And that's important to know. How do you diagnose long QT syndrome? In the old days, there used to be scoring systems. Dr. Schwartz, Peter Schwartz, had identified the one that was most commonly used, and you got points for degree of QT prolongation, whether you have torsade, macroscopic T wave alternans, which is a feature of this, where you can actually visibly see the T waves, change from beat to beat, low heart rate for the sodium channel mutations on QT3, syncope, congenital deafness in the family or in you, and a family history of long QT syndrome. We don't use the systems, the scoring systems as much now that genetic testing, is available. It's actually pretty good in long QT syndrome. We'll talk about that in a couple of minutes. Can you look at the EKG and tell what the gene is? And the answer is a lot of the times you actually can. People who are good at this can get it right about 80% of the time. And so this is how it goes. Long QT1, which is the potassium channel that decreases active potential duration at higher heart rates. At low heart rates, the EKG looks completely normal, and the QT interval and the corrected QT interval is actually reasonably normal. And if you look at the EKG, it looks normal. Everything is just proportionately a little too long, and when the heart rate gets faster, it doesn't shorten. Long QT2, these are the hERG mutations, funny T waves. So the QT is too long, and you have biphasic, funny T waves, especially in the precordial leads. Long QT3, here the QRS is normal, the T wave is normal, and the ST segment is just too long. And so this really has a, sort of a look to it that, you can pick out sort of from the other two. And like I say, people, sort of who are good at this can get it right sort of a pretty good part of the time. How do you treat long QT syndrome? Well, If you have inherited long QT syndrome, one of the things you want to do is avoid drugs that cause acquired long QT syndrome because you obviously have repolarization, inadequate repolarization reserve. The hallmark of treatment of long QT syndrome is beta blockers. So beta blockers are for long QT1 functionally curative, at least they're called that. In Europe, if you have aborted sudden death and you get and you show up with a long QT1 mutation, you get put on Nadolol, which is the beta blocker of choice, and you do not get a defibrillator unless you have recurrent arrhythmias on beta blockers. In the U.S., if you had aborted sudden death, you get Nadolol and a defibrillator. We'll talk a little bit about who gets a defibrillator in long QT syndrome. It's really the backup treatment. And in Europe especially, but also in the US, sympathectomy, which is sort of the ultimate beta blockade, is actually very effective in preventing sudden death from the potassium channel mutations. Note, for the sodium channel mutations, there's much less evidence that beta blockers do much that's good. Okay, so who's at high risk for sudden death and actually actually has an indication for defibrillator? Well, if you have aborted sudden death, that puts you at high risk, and we offer all of these folks defibrillators. The highest risk group aside for that are people who have recurrent symptoms, meaning either documented VT or arrhythmic syncope when they're on a beta blocker. Patients with very long QT syndrome and Javel-Lang-Nielsen are at high risk and have an indication for a device. QTC prolongation greater than 500 milliseconds is actually a very good predictor of long QT related arrhythmias and death. So, in some indications, some patients, that can be an indication for a device. Gender is interesting. QT is longer before puberty in boys. After puberty, QTC is longer in women. And then at old age, it becomes about similar in the two sexes. And this is hormonally mediated. So women have longer QTs and are more likely to get arrhythmias during, post-puberty. Family history, unlike in hypertrophic cardiomyopathy, is not a predictor of sudden cardiac death. That being said, this is for a single member of your family having sudden cardiac death. So the example I use is if somebody shows up in your clinic and says, hey, my sister had long QT syndrome and she died when she was 20, and my brother had long QT syndrome and he had aborted sudden death when he was 25, and my mom had long QT and she died when she was 30, and I was just told I have long QT syndrome. What do you think? The answer is, what flavored defibrillator would you like? There are clearly malignant families, and use common sense when you're taking care of, sort of people, if they come from a family with an incredibly malignant phenotype, because they're out there. I mentioned genotype-phenotype correlations. So long QT1 mutations, the arrhythmias here happen with exercise. Long QT2, as in the patient I presented first, these tend to happen not so much with exercise, but more with noise, with emotion, your brother dumping cold water on you. Long QT3, these tend to happen at sleep. They're bradycardia related, but pacemakers don't prevent them. So if people have a risk, they need a defibrillator. I mentioned that there are more malignant mutations, dominant negative ones that are actually affect the poor region of channels. And there are gene-specific therapies. The best one's beta blockers, which work really well on long QT1 and a little less well on long QT2. Turns out in long QT2, the hERG potassium channel is sensitive to potassium, so mutant channels work less well at low extracellular potassium. So you can raise extracellular potassium by giving people potassium and spironolactone. That shortens the QT interval. There's no evidence it protects you against sudden death, however. Some of the sodium channel mutations are more sensitive to sodium channel blockers than wild type channels. So again, you can normalize the EKG with sodium channel blockers like flecainide and mexiletine, but these can actually bring out Brugada syndrome. And again, there's no evidence that these prevent sudden death, so they should be used. in people who have defibrillators and recurrent shocks, but they should not be used at the moment instead of a defibrillator. So to summarize, long QT is a disorder of repolarization, dysfunctional potassium channels that decrease outward current, or sodium channels that don't inactivate, which increase inward current. There are genotype-phenotype correlations. They may lead and are leading to some gene-based therapy, and it's catalyzed a huge amount of work on the role of ion channels in the heart. If you like long QT syndrome, you'll love short QT syndrome. It is the opposite. It is too much potassium current, leading to short action potentials and short QT. Also, in some cases, not enough calcium current, sort of leading to short action potentials and short QT interval. Here's an example of an EKG with short QT interval. This is not subtle when it is severe. And when it is severe, these are incredibly arrhythmogenic and require a defibrillator. And as you can imagine, the defibrillators can have trouble with double counting, these, because the EKG is so funny. Now, we have plenty of drugs that prolong QT interval. So can we give people sotalol or some other drug that causes acquired long QT syndrome and normalize the QT interval here? The answer is yes, but again, there's no evidence that that prevents sudden death. And in people at high risk, they should get a defibrillator. Now, as we've genetically identifying short QT, and it's not just when we see EKGs that look like this, we now have short QT syndrome, which isn't nearly, where the QT interval isn't nearly as short as this, and again, that are not nearly as malignant as this, as we screen people in families, that have this. So not everybody with short QT automatically needs a defibrillator. Okay, I'll move on to Brugada syndrome, which is my favorite of the inherited arrhythmia syndromes. This is a sodium channel deficiency syndrome. So this is not enough inward current, not enough inward sodium current, or not enough inward calcium current, which, and these are some of the genes that have been identified as causing it. Now, Brugada syndrome is different than some of the other inherited arrhythmia syndromes in a couple ways. One is there is some structural defects if you look hard enough in the heart. Another thing is that it is usually polygenic, with the exception of mutations in the primary sodium channel. Mutations in the other genes don't probably, for the most part, cause enough of a decrease in the sodium current to actually by themselves lead to the phenotype. So there's really a lot of incomplete penetrance in this, and it's polygenic, which makes genetic testing not really as good. A recent paper on the genetics said that only sort of sodium channel mutations are really proved to cause Brugada syndrome. I agree with the generic idea that as a monogenetic cause, that's probably true, but there's pretty good evidence that all of these other sodium channel decreasing mutations are associated with long QT. In addition, there's genetic variants that are associated, common variants in addition to rare ones, that cause Brugada syndrome. So what is Brugada syndrome? It's characterized by an EKG pattern of a right bundle branch block with ST elevation that leads V1 to V3. It is interesting, the EKG can vary from day to day. So one day it can be basically normal and the next day it can have the full-blown pattern. We think it's probably metabolic is the reason that that is the case. It is autosomal dominant, but with male predominance. So 80% of people who have arrhythmias, 80% of people who have the full-blown EKG pattern are men. Fever brings it out, again, metabolic. There is some structural heart disease, and although it's rare in parts of the world, it's actually quite common, specifically in Southeast Asia, in parts of Thailand, Vietnam, Southeast China, parts of Japan. And it's not that there was one guy 10,000 years ago who had a lot of kids who populated the region. There's something else there, and we haven't still figured out exactly what it is in that region that makes Brugada syndrome more common than in other regions. Interesting stories that come out of it in parts of Thailand, in small villages. It's known that it's the most common cause of death in families that have this thing in young men. So, and it's known that it doesn't affect women all that much. So in some of the villages, men dress up as women at night before they go to bed, because this is one of the ones that kill people at night. In general, in the inherited arrhythmia syndromes, there's no randomized controlled trial data showing that, sort of one treatment is better than the other. And there's no randomized controlled trials that show that dressing up as a woman when you go to sleep prevents sudden death. And my guess is it probably wouldn't work. Anyways, genetic testing is not as good in Brugada syndrome. It only identifies about 30%. It's only positive about 30% of people who have defined definite Brugada syndrome. I mentioned that there's common variants that affect it. Oftentimes, families have both an inherited and a mutation and a modifier variant, and I'll show you a family like that. And as I mentioned, only families with the sodium channel mutation have been reported to reach the threshold for causality, although others of us would potentially argue with that. Same presentation as inherited LQT syndrome, syncope, sudden death, seizures, sudden infant death syndrome. The mechanism of Brugada syndrome, it is aborted action potentials. At least that's the mechanism that Dr. Ancelovich has championed. So if you don't have enough inward, so normally action potentials are longer in the endocardium than in the epicardium because there's more of a polarizing potassium current in the epicardium. If you don't have enough depolarizing sodium current in the endocardium, it doesn't make much of a difference. But in the epicardium, you can get an aborted action potential where you repolarize completely. If your epicardium is back at minus 90 millivolts, while your endocardium is still at plus 10 millivolts, you can get the spread of activation again through the wall of the heart called space to reentry and the initiation of reentry and arrhythmias. So that is the mechanism that is most commonly considered as causal of Brugada syndrome. Now, the other mechanism that is brought up is, you can get the same picture by if you have very slow conduction and conduction failure in the epicardium, then you'll end up with the same thing. And, there's evidence supporting both of those mechanisms. They're not mutually exclusive, and they can both be true potentially in the same person. How do you diagnose Brugada syndrome? Well, again, it's the syncope, aborted sudden death, family history, and the EKG pattern. I'll show you the typical EKGs in a second. This is a sodium channel deficiency syndrome. So sodium channel blockers bring it out, and I use clinically. In the US, we give people IV procainamide or high dose over 20 to 30 minutes. In Europe, ajmaline, a better sodium channel blocker is used, and it's more effective. Because it's a sodium channel mutation, you can look for abnormal conduction in the heart. You will usually find it in Brugada syndrome, especially for the sodium channel mutations. And I mentioned molecular diagnosis. These are the EKG patterns. The diagnostic pattern is type 1, which is coved ST elevation with an inverted T wave, usually present in leads V1 to V3. Type 2 and type 3 are saddleback patterns. Saddleback because you consider it's a right bounded branch block pattern with an upright T wave and ST elevation. 2 millimeters ST elevation gives you a type 2 pattern. 2 less than 2 millimeters gives you a type 3 pattern. If you do a drug challenge, you can convert type 2 or type 3 into type 1. If you raise the leads on the EKG, raise leads V1 or V2 a couple interspaces, you can turn type 2 into type 1. The type 2 and type 3 patterns are not diagnostic. Up to 1% of the population has a type 3 EKG pattern at baseline. So these patterns are not Brugada syndrome, but if you're worried, you can do a procainamide challenge and see whether somebody actually has it. What's the treatment? Well, avoid sodium channel blockers. That's easier than avoiding potassium channel blockers. People at high risk, it's a defibrillator, and then the problem is who do you call at high risk? Aborted sudden death? Yes. If you have a type 1 baseline Brugada pattern and arrhythmias, yes, you have an indication for a defibrillator. If you have syncope and a type 2 pattern and you think it's arrhythmogenic, yes, defibrillator. If you're not sure, unclear, type 1 pattern, you're at higher risk, but is it enough for a defibrillator? Dealer's choice. If you just have a identified genetically as a carrier or a pattern brought out by a procainamide challenge, no indication for a defibrillator. Can you treat it by blocking outward currents? So we said this is an imbalance of outward and inward currents. So quinidine does that. You can normalize the EKG with quinidine, but again, this should not be used instead of a defibrillator in people at high risk for sudden death. Okay, let's talk about a few cases. We can bring out, sort of some of the ones that we've dealt with, and this, I think, shows, some of these show the weaknesses of how we deal with these inherited arrhythmia syndromes. So this is the EKG over here of a 45-year-old guy who presented to us in Pittsburgh with a syncopal event. He had a type 1 Brugada pattern, again, ST elevation code with inverted T waves. His syncope for all the world sounded vasovagal. And so the question was, baseline type 1 pattern, do you put a defibrillator in him? He's a nervous guy. We put a defibrillator in him. He's a nervous guy. He tortured us, and we'll talk about that for a little bit. Went ahead and screened his family. His sister, who is unusual, carries a DSM-5 diagnosis. She had despite being a woman, had a baseline type 1 EKG pattern. She said, I don't want to have anything to do with this. Don't go anywhere near my children. I'm out of here. And that was the last we heard from her. The proband had 2 kids. His younger son showed up in Children's Hospital with what for all the world sounded like a vasovagal syncope event and had a baseline type 1 EKG pattern, seen by our pediatric cardiologist in Pittsburgh at the time. And they were convinced that this was the vasovagal, and given that he was 14, thought the risks were greater than the benefit of a defibrillator and did not offer him one. His sister, who was a year or 2 older than her brother, had a slightly funny EKG, but not a type 1 pattern, and was not offered a defibrillator. Along with Sam Dudley, we did genetic screening. This was early on, so we did it in the lab, and we identified a mutation, and that's actually a trafficking mutation in the cardiac sodium channel NAV1.5. So decreased sodium current. If we actually get the channel out to the membrane, which we could do with blockers, and then remove the sodium channel blocker, the channels function perfectly well. So a classic trafficking defect. So we could go ahead and screen the family. And so we went ahead and screened the family, and then followed them for the next 15 years. And this is what happened. So the proband now he's on his 3rd defibrillator, 13 years later, is incredibly nervous, complains incessantly that he's worried about having a defibrillator, but still wants a defibrillator and has never had an event. Never heard from the crazy sister, but the daughter of the sister was out to dinner in Florida and had a witness cardiac arrest. She was fortunately resuscitated, had a baseline type 1 Brugada pattern, and has a defibrillator and is living okay now. So not perfect, but a reasonable result. The son of the proband, he turned 18, was transferred to our adult group, was offered a defibrillator, he declined. At age 28, he was working under a car, changing the oil on his car, and had a sudden death. By the time it was identified that he was dead, he was not resuscitatable. So we knew he had the mutation, knew he had a type 1 pattern, and couldn't prevent his sudden death. His sister, who never had a full-blown pattern, was offered a defibrillator by our EP group. She accepted it, has never had an arrhythmia. So an example where we know the genetics, we know the molecular basis, and we still can't really predict who's at highest risk, and had some good luck and some bad luck in the family. Okay, here's a second family with Brugada syndrome. So I met this family when this woman showed up after the death of her second son. So her first son had witnessed sudden death, was resuscitated, but suffered brain damage, was in an institution. He had a funny EKG, which was Brugada syndrome, although it was early enough that the docs who saw it didn't identify it as being Brugada syndrome. Mom told the other 2 kids, go see a cardiologist. So the son, this guy, saw a cardiologist in metropolitan Pittsburgh. He had a classic type 1 Brugada EKG pattern. The cardiologist didn't identify it, put him on a treadmill. The pattern got better, which it often does with exercise, and said, did a Holter, there were no arrhythmias, and said, you're okay, don't worry about it. Couple years later, he got married and had his first kid. The night after his first kid was born, after he left the hospital, he went out to a bar and had a drink with a friend. He had sudden death on the bar stool and was not resuscitatable. At that point, his mom came to us. She had a borderline type 1 pattern, and we offered her, and she got a defibrillator. We screened the rest of the family and actually identified a first cousin in Boston who was an EMT who actually had a type 1 Brugada pattern and a history of near syncope. So he got a defibrillator, as did his dad, who had an abnormal EKG and actually some structural heart disease. So this is an example of it takes the second event in a family to get it. And we molecularly screened the family, and we found a known mutation that causes, in the sodium channel that causes Brugada syndrome. But we also found a mutation in a helper gene, and only people who had both the mutation in the gene and the helper gene actually were clinically affected by EKG. So an example of the polygenic nature of Brugada syndrome. Final example of Brugada syndrome I'll do is, so this is the family we used to identify the second Brugada gene. So 55-year-old guy who had syncope at work, fainted into an egg salad sandwich, showed up in Erie, in a hospital in Erie, Pennsylvania with this EKG, right bundle, ST elevation. They said, you're having an acute anterior wall MI. He said, I don't have any chest pain. They said, no, you're having an MI. They took him to the cath lab. He had clean cores, had a normal echo. They sent him to us for an MRI, thinking it might be arrhythmogenic right ventricular cardiomyopathy. And Kelly Anderson, who was in an electrophysiologist in Pittsburgh at the time, identified this from the original paper of the Brugada brothers as the right bundle branch ST elevation syndrome that he had. We gave it to one of the young electrophysiologists who called me, and said, do you want to study this thing? We hear, it can be inherited, according to the original Brugada report. And I had never touched anything but a mouse. I didn't do human genetics, but fortunately I was smart enough to look at this family and say, I think we want to study that family, and did. The question, what to do with the patient, he was offered a defibrillator, he accepted it. 6 months later, he didn't feel well, and his wife was driving him to Pittsburgh for an appointment, and he had 2 syncopal events in the car. And this is the telemetry from his syncope, and he was shocked twice back into sinus. And this shows the issues with these inherited arrhythmia syndromes. So it's now almost 20 years later. He had 1 syncopal event into an egg salad sandwich, 2 aborted sudden death events with documented ventricular fibrillation, and nothing else. So his defibrillators have picked up no other complex arrhythmias in the 20 years that he's had his defibrillators. So what is it on the days that, he obviously has a substrate that, makes him susceptible to sudden death, but what is it on the days where he actually dies that causes these events once every several decades? And how do you predict that? And the answer is there's probably no particularly good way. This is his family, who all live in Erie, and we actually used this family to identify a mutation in a sodium channel trafficking gene, GPD1L, and mutations and lead to decreased sodium current. So Brugada syndrome is a disorder of decreased depolarization. Decreased sodium current leads to loss of the action potential plateau, premature repolarization, transmural current flow, and reentrant arrhythmias. I will just really briefly talk about the other inherited arrhythmia syndromes, catecholaminergic polymorphic VT. This is mutations in the ryanodine receptor or other calcium handling genes. These lead to calcium overload delayed after depolarizations and arrhythmias. Here, the EKG is normal at baseline, but if you give people isoproterenol or other beta agonists, or you have them exercise, they'll develop PVCs, ventricular tachycardia, and a classic rhythm of bidirectional VT, where you have PVCs of alternating morphology leading to ventricular tachycardia. Again, the same symptoms, except here you can use an exercise test or an isopril study to bring out the arrhythmia. treated by beta blockers. Calcium channel blockers don't work. Defibrillators work, but they can precipitate VT storm by leading to, sort of, more adrenergic stimulation when your defibrillator goes up. And it turns out sodium channel blockers, flecainide and its cousins, actually are very effective, probably by acting as right-adenine receptor stabilizers in addition to the sodium channel effects. I won't talk about ARVC. I just show you an epsilon wave, but this has the same arrhythmic features, but also right and then left ventricular dysfunction and and this is a desmosomal mutations, and hypertrophic cardiomyopathy, which is sarcomere mutations that have their own phenotype. Okay, so somebody shows up in your clinic with worried that they may have an inherited arrhythmia syndrome. A couple of their relatives have dropped dead. What do? Well, you take a history and history of syncope, you have some syncope, palpitations, born sudden death. You ask them whether anybody, and do a family history, ask them whether anybody in their family has pacemakers, defibrillators, sudden infant death syndrome, late term miscarriages. You ask them whether they have a history of aborted sudden death. You'd think you don't need to ask them that, but in fact you do. I saw somebody a few months ago who, sort of family history of sudden death, and I went through the whole history, and at the end of it, I said, I asked her and her husband, anything else I should know? And her husband looked at her and said, Judy, do you think you should tell him about the time you stopped breathing? And I said, I'd like to hear about the time you stopped breathing. And he said, well, there was this time we were watching TV, and all of a sudden, Judy, just slumped over and stopped breathing, turned blue. I laid her down, was about to do CPR, and then she woke up. And, we never did anything about it. What do you think? And I said, yeah, again, what flavor defibrillator would you like? And so, so good to ask about stuff. EKG, you can identify long QT syndrome, short QT syndrome, Brugada syndrome by the pattern. Structural defects also lead to abnormal EKGs. You can pick out the structural problems by MRI and especially echo, not quite as good, but you can see, sort of, abnormalities there. Stress tests are useful for long QT1, where the, QTC will get long as the heart rate gets faster, and catecholaminergic polymorphic VT, where you'll bring out arrhythmias. Drug testing, sodium channel blockers for Brugada syndrome and beta agonists for CPVT, and EP studies. You can pick up conduction disease in Brugada syndrome and the other sodium channelopathies. This question as to whether program stimulation causes BF in Brugada syndrome, it's unclear how useful it is as a clinical test. We don't usually use it. Treatment can range from nothing to avoiding medications that exacerbate the condition to avoiding competitive sports. That's a hard one. If you have one of these conditions where exercise brings out the condition, should you avoid high energies, burst competitive sports? Probably yes. How about if you have Brugada syndrome, where exercise actually doesn't bring it out, it's actually protective? Should you not do competitive sports there? Well, the answer is probably it doesn't make any sense to tell people they can't exercise. But then again, if you're a high school coach and you're worried that you're going to get sued if somebody drops dead while exercising, which could still happen, you may tell them not to do it. And that's sort of an issue. Pharmacologic treatment, the best one's beta blockers for long QT syndrome. Defibrillators, and these are context dependent. And this is very different than the decision of defibrillators as primary prevention for somebody who has heart failure. If you have heart failure, you need about a 5% a year risk of sudden death to make it worthwhile for you to have a defibrillator. But there you have a competing risk of death from heart failure and a life expectancy that's usually 5 years or 10 years or less. If you're a 20-year-old who just had their first kid who has long QT syndrome, a 1% a year risk of sudden death is probably unacceptable, and you probably should be offered a defibrillator. And again, these are personal decisions as to how you would like your risk and what is the risk of the device as opposed to the risk of sudden death. And with sub-Q defibrillators now, the risk is lower. Occasionally, these people will go all the way to artificial heart devices or heart transplant. That is less common now that we have some of the, that we have high-dose amiodarone and that we have ablation, which works, sort of as an adjunctive agent in a lot of these conditions when you have malignant arrhythmias, along with sympathectomy. But occasionally it still happens. It turns out the insurance carriers will pay for defibrillators in these inherited conditions. They don't require any of the stuff that they have often on required, sort of in patients with heart failure for primary prevention devices, for reasons that make pretty good sense. If you have one of these conditions, it is a class 1 indication that your first degree relative should be screened for it. So if you have long QT, your relative should get an EKG. If you have a structure 1, should get an echo and an EKG, and anything else that makes clinical sense. And then you cascade through the family. So anybody in the family with symptoms should be screened, and then you do first degree relatives or the closest available relative. And if then they have it, you do their first degree relatives, and you try to identify this. You'll also see people show up in your clinic who are there because a kid usually has been screened by whole exome screening, and there are a number of mandatory reportable genes. So someone will show up and say, I found out I have a sodium channel mutation, and you treat them the same way you would anybody else who may or may not be symptomatic, or with the genetic condition. The question of, do you screen all kids? The Italians do. We don't have enough pediatric cardiologists to actually look at all the EKGs. And a question of, should you screen all school-age athletes for hypertrophic cardiomyopathy and long QT? The answer is probably yes, if you could afford it. And I think we as a society have to decide whether we want to actually do that. Last thing I'll talk about is genetic testing. It's pretty good if you have one of these conditions, with the exception of Brugada syndrome. The genetic pickup is well over 50% in most of them. The best use of genetic testing is if you identify the causative gene, you can screen family members with a blood test and identify who doesn't have it and who is at no risk for actually getting the condition. Sometimes you can use it to identify who should get prophylactic beta blockers, for example, in long QT1. There are still, and then once you identify it, you can, do cascade testing, except you do it with a blood test instead of with an EKG and an echo gene. The advantages of genetic testing, you can identify people who are affected, tell people who to avoid types of drugs, potentially, treatment, pre-symptomatic treatment. And as I mentioned, you can tell people who don't have it, they have nothing to worry about. Problems with it, insurance coverage is getting better. I think the biggest issue is there's a lot of variants that we don't know whether they're causative or not, so it doesn't always give a clean answer. And this is a new field, and the conclusions can still be long. This is a list of some of the sites that do genetic testing. And with that, I will stop, and I want to thank everyone, for inviting me to give the talk.
Well, thank you very much, Dr. Linden. That was an informative and entertaining talk. So we're running a little bit late, but we probably have time for 1 or 2 questions. And then any additional questions could perhaps get emailed to Dr. Linden directly.
Yeah, and I'm happy to answer any questions by email or otherwise.
I've got a question for you, Barry. A very common situation is an incidentally found type 1 Brugada pattern. You see the patient, there's no family or personal history of syncope or arrest. Where do you go from there?
Yeah, and that's a real problem, because the people clearly have an increased risk of sudden death. The risk is relatively small. If people have looked at sort of people who have sudden death or avoided sudden death in Brugada syndrome, and only about a third of them have a real hard indication for a defibrillator before they were identified as having a lethal, sort of cardiac event. I think it's a personal decision, for between the patient and their electrophysiologist, sort of as do they think that there is a high enough risk. I think you can, the use of loop recorders, you can do that. The problem is, though, that you can go 2 years with nothing and then have a lethal event. I think if somebody's made it, I think if somebody's made it to age 70, and they show up with a type 1 Brugada pattern, the risk is higher when you're younger. So probably in that group, I wouldn't do it. Certainly kids, we don't do it in, because, at least till you're an adult, the sort of the risk of having a defibrillator and the tolerance is lower. But I mean, I think, the ICDs are safe enough now that one can make the argument that if you have a 0.5% to a 1% a year risk of sudden death and you want a device and you're willing to accept the annoyance of and the side effects of the device, it's probably not unreasonable. But you're absolutely right. Now, there is one paper that's come out looking for, using drug testing to try to predict who's more likely to actually have an event. So they gave people procainamide, and the people who had a ton of ST elevation or arrhythmias had a higher risk. There's an assortment of other, sort of studies that are out there trying to identify, what predicts, a higher risk of sudden death. So probably we'll be able to substratify this group a little bit, better in the next 5 or 10 years. But I still think we're going to end up with okay, you have a risk of somewhere just less than 1% a year. What do you want to do? And I think that quandary is going to remain.
All right, well, excellent. If there, Fadi, did you have a question?
No, go.
No, feel free.
It's okay. Just very, very quick question, Barry. I was, hoping to get your insight about some of the mutations that cause an overlap syndrome, which maybe didn't highlight, with Brugada can be, overlapping with ARVC or with short QT syndrome. And are there particular challenges in treating those mutations?
Yeah, so there's all sorts of challenging overlap syndromes. So there's sodium channel mutations cause conduction disease, long QT3, and Brugada syndrome. And there's families that have, one mutation that in any given person will cause A, B, C, A plus B, A plus C, etc. And, sodium channel blockers, which can make long QT3s EKG better, can cause Brugada syndrome. Now there are calcium channel mutations that can cause Brugada syndrome and short QT syndrome, or so you have Brugada with a shortest QT interval. And so there's, sort of some evidence which will be published shortly that is going to say that, Brugada patients with a shorter QT are more likely to have calcium channel mutations in them. It's pretty rare though. And so and there is a structural overlap in Brugada syndrome. So initially Brugada syndrome was thought to be sort of a pure channelopathy, but if you start doing autopsies on people, you'll see that there's inflammation and cell loss in the, in the septum and the, in the epicardium of the right ventricle. If you do EP studies, you'll see evidence of low voltage in those areas that look like structural problems. If you do high resolution MRIs, you'll see subtle fibrosis in some people. So it's interesting. What it says is that, these pure ion channel mutations can ultimately lead to presumably cell death and then a structural. Exactly why that happens, why it happens in the right precordial leads more than other places. A lot of stuff that we don't fully understand, sort of just yet. I mean, we use animal models. The mouse is a challenging model to use for most of these because the, arrhythmias are so different in the mouse. The heart rate is 700. The potassium channels that are relevant in the mouse have nothing to do with the ones that are relevant in humans for the most part. Sodium channels are a little bit better, but the phenotypes are different. And it's hard to make large animal models, although, sort of Glenn Fishman actually made a large animal pig model of Brugada syndrome, but then it died out. So we got one JCI paper and then, sort of a deadline of pigs, so that was probably a long run for a relatively short slide. So I'm not sure how many people want to spend, $500,000 to do that again.
Well, thank you very much, Dr. London, and thank you everyone for joining us and for sticking around a little bit late today. We'll see everyone next week. Thank you.
Thank you, everyone.